Okay, we are live. We can begin.
Hello everyone, myself Dr. Rahul Mandlik, heading medical affairs at Shalina Healthcare Dubai. On behalf of entire Shalina Healthcare colleagues, I would like to welcome our participating healthcare professionals to this webinar. I would also like to extend warm welcome to our speaker, Professor K.D. Rensford. Well, before we start this webinar, I would like to quickly take you through our corporate profile. From last 35 years, it has been our mission of making quality healthcare products and also to make them available at affordable prices across Africa. Today, we are one of the largest pharmaceutical companies in sub-Sahara Africa, and we market around 350 products spanning across 12 therapeutic areas. We manufacture these products at our own WHO quality approved facility, and we procure some of them from other WHO approved facilities. Over last 35 years, it has been our top priority of delivering continuous education for healthcare professionals. And today's technological advancement has enabled us to roll out online educational training programs which are attended and well appreciated by thousands of doctors, pharmacists, and nurses across Africa. In this endeavor, today's this session is going to highlight the importance of multimodal analgesia in the management of acute pain. And we take great pride in announcing that today with us is one of the world's renowned expert from this area of pain and inflammation, Professor K.D. Rensford. Professor Rensford is Emeritus Professor of Biomedical Sciences at Sheffield Hallam University, UK. Sir has got more than 50 years of experience of medical and biomedical sciences teaching in 5 Commonwealth countries and Switzerland. His areas of interest are inflammation, pain, and anti-inflammatory drugs. Professor Rensford is founder, editor-in-chief of Inflammopharmacology, and he is a member of editorial board and referee of several high-impact journals. Professor Rensford is external grant referee at reputed research institutes and organizations, and he has established several research programs and centers at many universities and research institutes in Canada, UK, USA, and Australia. Professor Rensford has got featured in Who's Who in the world from last 2 decades and also in Who's Who in medicine and healthcare. Talking about his scientific immense contribution, he has published more than 200 original research articles. Professor Rensford has written 29 books. Well, the chapters written by him are not mentioned here, and he has presented close to 200 abstracts and presentations at international platforms. Talking about the books, 29 books, out of which 3 of them Professor Rensford has written on ibuprofen, and they have been published with very reputed publishing houses like Taylor and Francis, Springer, and Wiley Blackwell. While you attend this webinar, and if you have any questions, please feel free to post them in a box just placed on right side of the screen. Well, without taking much time, now I would like to hand over the session to Professor Rensford. Over to you, sir. Thank you.
Good afternoon or good evening, depending on where you are. It is through this extremely elegant technology that I have the great privilege of being able to talk with you about methods for the control of pain, the mechanisms of pain controlled by analgesics, and in particular, the use of what we call a 3-pronged multimedia attack for the control of pain, that is by using 3 different drug combinations. Okay. Now, the scope of my talk is first of all to briefly mention to you about what inflammation is and the pain mechanisms of analgesics and non-steroidals with and without caffeine. The concept of analgesic ceiling as an intrinsic limitation to pain relief from analgesics and non-steroidals with a focus on ibuprofen, and how this analgesic ceiling may be elevated through multimodal analgesia, that is by the additional use of paracetamol and caffeine. And the clinical benefits from ibuprofen, paracetamol, caffeine combination also I will discuss. Now, this cartoon, which was actually created by a late friend of mine, of inflammation, showing the 4 original cardinal signs and symptoms, being swelling, pain, redness, and heat. These, of course, variably occur in inflammatory conditions. And in severe arthritis, the extreme situation, there may be loss of function. The definition of pain has been presented by the International Association for the Study of Pain as an unpleasant sensory and emotional experience associated with the actual or potential tissue damage or described in terms of such damage. Pain is mediated by chemical mediators, and you probably know them quite well as things like histamine and prostaglandins. They activate specific pain receptors in tissues or cells. The process of activation of pain pathways in the peripheral and the central nervous system leads to psychobehavioral and sensory experiences. Pain can be protective. In limited studies that have been undertaken in children that have shown a congenital deficiency in sensory transmission, show that self-mutilation is due to this congenital sensory deprivation. And it highlights the very point that pain can be protective. We differentiate between acute and chronic pain. Acute pain is a normal, predicted physiological response to an adverse chemical or mechanical stimulus associated with trauma, surgery, acute sickness, illness, and accidents. Activation of nociceptors, that is, pain perceiving receptors in cells, occurs from the inflammatory soup, as it's called, the mixture of all the inflammatory mediators, and that leads to transduction of signals by nerves into the spine. Chronic pain results from a transition from acute pain, repeated acute pain in some cases. It's time dependent and can occur upwards of 6 months after acute injury or pain. It's associated with prolonged tissue injury, such as arthritic joints and in some cancers. There's a variable but important psychological response to pain perception. And you probably well know this as the way in which people get very anxious or very concerned about their pain, and maybe this develops into psychopathological consequences. So we talk of the elements of pain. There are types of pain, acute and chronic, which we've mentioned. Acute can have a warning signal. Chronic pain may not be associated with a warning signal. They've got a variable onset, and the severity may be disproportionate. Whereas an acute injury, for instance, the severity correlates quite well with the degree of injury, such as in a fracture or soft tissue injury. In chronic pain, such as in low back pain or severe joint arthritis, there may be variable onsets. Some days patients have better days, as they call them, than others. Then we talk about the mechanisms. There may be nociceptive mechanisms, that is, the pain signals transmitted to specific receptors, and neuropathic pain, which is a result of damage to nerves, and that may be quite severe in its consequences. One of the key elements that we talk about is the involvement of the prostaglandins in the mediation of this pain. The prostaglandins are generated from cell membranes when they have been damaged or otherwise inflamed. And this leads to activation of the enzyme phospholipase A, cleaving lipids from the membrane to produce arachidonic acid. And arachidonic acid is an unsaturated fatty acid, which is oxidized by the enzyme cyclooxygenase. And this is a component, the release of prostaglandins and the eventual transport out is the component of prostaglandin synthesis. Now, if we look at some of the key mechanisms that are involved in the inflammatory process and the activation of nerves into the spinal cord, and from there ascending fibers into the higher centers of the nervous system, and then descending fibers, these may be activated variably depending on the severity of pain. And the non-steroidal anti-inflammatory drugs and paracetamol, which is not a non-steroidal but is a non-narcotic analgesic, have varying effects on these different pathways. And the mediators that are released are not only prostaglandins, but nitric oxide, NO, or components of the nerve system neuropeptides. And these all variably have effects on C fibers and to some extent on A delta fibers. These are the key fibers that go into the dorsal horn and project into the higher centers of the nervous system. Now, the non-steroidal anti-inflammatory drugs, in affecting prostaglandin and other components from cyclooxygenases, are inhibited in their production by ibuprofen, like that of many other non-steroidals. But there are two components to ibuprofen. One of them is the S form, which is the inhibitory form, inhibits the prostaglandin release. And there's the R form, which has actions with S in the higher centers of the nervous system, involving the release of noradrenaline and 5-hydroxytryptamine. And these may have inhibitory effects on the downward pathways. This is seen a little bit more in detail here, where the inflammatory and pain-producing mediators, cyclooxygenase, nitric oxide, acting on components of the nervous system, are blocked by ibuprofen, that is the S-ibuprofen, and this stops the upward transmission of pain perception through the spinothalamic and reticulothalamic pathways. So the transmission into the cortical region and into the thalamus is effectively controlled or blocked by the actions of ibuprofen. Separate to this is that in the higher centers, it's believed that the inhibition of prostaglandins can be responsible for the actions of paracetamol. Paracetamol also has effects on inflammatory cells, but it's not known exactly to what extent quantitatively this is evident. But ibuprofen and paracetamol do have differing actions on these afferent pathways in transmission of the nervous signals, and that's a very important component of their total analgesic action. In addition, the downward pathways that impinge upon the spinal cord, these are activated by drugs like ibuprofen, and ibuprofen actually has an effect on the production of an endogenous cannabinoid and leads to activation of adrenergic and serotonergic pathways. So this is quite a different action of ibuprofen and some other non-steroidals, which has been highlighted over the years of research into the actions of the mechanisms of action of non-steroidal and paracetamol. In addition, I mentioned about pathological pain or neuropathic pain in nerves. Pardon me. This can result from damage to nerves and in the release of inflammatory mediators such as interleukins, tumor necrosis factor, interleukin-6, nitric oxide, as well as prostaglandins and ATP. These mediators cause variable effects on axons in nerves and are responsible for the development of chronic pain. As you know, neurological damage leads to chronic neurological injury and pathological pain as a consequence of this. Now, going back to the story about ibuprofen and the links to prostaglandins and pain. Very important issue here. First, as I mentioned, we have two components here of ibuprofen, two chemically similar but different components. First, there is the R-ibuprofen, which has been shown to accumulate in the same way as S-ibuprofen in inflamed joints. Shown in the lower part here is the accumulation in synovial fluid of both of these. But you'll notice that the R-ibuprofen has a much higher concentration in the plasma as distinct from the S form. And what we know is that the R form, a proportion of this gets bioconverted to the S form, and then that accumulates in synovial tissues. So you may say, oh gosh, this is a complicated story, but it's a very important one because S-ibuprofen directly affects the production of inflammatory prostaglandins and thromboxane. The R form probably affects inflammatory cells that are producing these prostaglandins. And this is shown here in this slide, where the red color is the S form and the R minus is the blue form. And the blue form, ibuprofen, gets into inflammatory cells, leukocytes, and causes the reduction of a range of inflammatory mediators there, such as nitric oxide, oxyradicals, and nuclear factor kappa B. Whereas the S form directly acts on COX-2, the cyclooxygenase, and this results in the reduction of inflammatory mediators that are derived from COX-2. The rest of this shows the metabolism of the two parts through the formation of glucuronides and other metabolites. Now, a very significant and important observation was made probably about 20 years ago in studies involving dental surgical pain, where, for instance, third molars are removed, and this leads to a very striking effect with ibuprofen, which has a powerful reduction in total pain, or in the sum of pain, over the dosages up to 400 milligrams. You see, the limit here, even with what is a high dose of ibuprofen, is that only about 80% reduction in pain that is over 50% of intensity is achieved. And this is essentially a limitation to pain control by ibuprofen. It's the analgesic ceiling. What we aim to do with adding other anti-inflammatory or analgesic agents is to try and increase this analgesic ceiling to make it more effective. So caffeine has been considered as one such additive. It's had a long-standing use in over-the-counter analgesics, such as aspirin-containing preparations. And small doses have been added and found very effective. Empirically, probably about 50 or more years ago, caffeine was added to a number of these APC preparations, either aspirin phenacetin codeine, aspirin paracetamol and codeine, or aspirin paracetamol and caffeine. In recent studies, the effective dose to achieve analgesic adjuvancy, as it's called, is about 4 milligrams per kilo. This is quite small, actually. But research on the neurophysiology of caffeine has shown that its major effects are due to actions on a group of purinergic nerves known as adenosine receptors. And these are evident in the nociceptive terminals and in the spinal cord. And adenosine receptors are affected by caffeine because the chemical structure of adenosine and caffeine is very similar. So that caffeine has an effect that resembles adenosine, but is a blocker of adenosine. So it stops this whole activation process. A very, very important and additional effect is also that it has actions on phosphodiesterases. And this way, it probably is a central nervous stimulant. In quantitative studies comparing analgesics like ibuprofen and paracetamol with caffeine have been performed by the Oxford Pain Group, headed by Andrew Moore and his colleagues. And here we look at the data that has been shown to be from ibuprofen 400 milligrams, single dose, in acute surgical pain, dental surgical pain, and the benefits and what is known as the number needed to treat. Now, this is a funny quantitation, but it is one which is very effective in discriminating analgesic benefits of different analgesics and combinations of them. And you see in these studies that the benefit from 400 milligrams affects about 4.7 of the proportion of patients. The number needed to treat is 2.3. But these benefits increase when ibuprofen or paracetamol are added to paracetamol and ibuprofen, and paracetamol and caffeine are added, and you see the benefits go right down to 2.2, and that's a very good value. That's quite a potent effect. Combinations of ibuprofen and caffeine have not only been examined in dental surgery, and one of the earlier investigators was Dr. Forbes from the United States, and he and his colleagues compared the effects, they were dental surgeons, compared the effects of doses of 50, 100, and 200 milligrams of ibuprofen in the presence of caffeine. It's actually quite a high dose here, although it's about the same as would be found in a cup of coffee. And the addition of caffeine to these doses of ibuprofen showed there was a quantitative improvement in pain relief achieved by the subjects that had additionally caffeine. And these were all much greater than placebo. Henry Mackay in Oxford showed that 200 and 400 milligrams of ibuprofen in the presence and absence of 50, 100, and 200 milligrams caffeine showed again a progressive and a much greater pain relief than either that with ibuprofen alone or even with caffeine alone, and all were much better than placebo. Po and Li Pengwang have shown that caffeine enhances analgesia in a number of studies in post-operative pain. And in systematic reviews and meta-analyses, and these are considered the gold standard of being able to determine the clinical benefits here, there's a clear dose response of 50 to 100 milligrams of ibuprofen, but the addition of caffeine greatly enhances this and reduces the analgesic ceiling. Systematic reviews, for instance, such as those by Derry, who's part of the Oxford group, has shown the number needed to treat in 334 patients with ibuprofen 200 milligrams and caffeine 100 milligrams was greater when caffeine was added, compared with that of ibuprofen alone or caffeine alone. And in a very large review, or Chinese colleagues in 3,521 patients, that's a lot, showed the pain scores of the sum of pain scores or the total pain relief with ibuprofen 200 milligrams with either 100 or 200 milligrams of caffeine was greater than that of 200 milligrams of ibuprofen alone. So there's good evidence that caffeine has an enhanced analgesic effect compared with that of ibuprofen alone. It's also long been known that caffeine has benefits when given with paracetamol or ibuprofen in the control of headache and migraine. And in one randomized controlled trial in 301 subjects, Ray Diamond and his colleagues showed that the addition of caffeine with ibuprofen gave better pain relief than with ibuprofen or caffeine alone, and all were much better than placebo. So there's good evidence for the benefits of caffeine. Then is the influence of paracetamol with ibuprofen in the control of dental pain. And this study by Don Millish in the United States showed that the pain relief and intensity differences were affected by both these treatments in a dose-related fashion. In comparison with placebo, and paracetamol, which has some benefits that are more short-term over the first hour. And in comparison with ibuprofen, which has got a much longer period of pain relief, the addition of these two drugs together showed there was a marked reduction compared with either of the drugs alone. At the lower dose of 200 milligrams of ibuprofen or 500 milligrams of paracetamol. At the higher doses, the pain relief extended over periods of up to 6 hours, 8 hours. And that was very, very effective. And this has been another good reason to combine ibuprofen and paracetamol together. Similar effects are shown in the intensity differences in pain relief, and it's almost identical. Combinations of ibuprofen, paracetamol, and caffeine have been examined recently in third molar surgery or in periodontal surgery. And again, we find that 400 milligrams of ibuprofen with 600 milligrams of paracetamol and low doses of 15 milligrams of caffeine in preemptive analgesia were examined in 54 patients with visual analog scores recorded before and up to 8 hours afterwards. And the combination here of the three components was much more effective than placebo, with a maximum effect evident at 4 hours. Similarly, in periodontal surgery, what's called open flap debridement, which is a very unpleasant periodontal treatment, I might add, of course, with the combination of the ibuprofen, paracetamol, and caffeine, led to marked reduction in pain ratings over the period of 2 to 5 hours, and after continuous treatment, up to 3 days. In this study, by the way, diclofenac was employed as an escape analgesic, but there were very few patients that needed to have that escape analgesic. It was greater combination effects and pain relief compared with controls. Now, if we look at the overall picture of non-steroidals, we're not looking at paracetamol here, we're looking at non-steroidals. And what are the issues that are present and why we would choose ibuprofen? In terms of gastric safety, which we know is a result of symptomatic and pathological side effects. By pathological, I mean the development of ulcers and other lesions. Non-steroidals are associated with symptomatic and pathological side effects, but ibuprofen is associated with fewer gastric adverse drug reactions compared with aspirin, diclofenac, or most other non-steroidals. In non-chronic pain, ibuprofen is recommended as a first-line treatment for this important pain entity with mild to moderate pain. Ibuprofen produces a fast onset of action compared with other drugs like diclofenac, aceclofenac, which is an analog of diclofenac, or aspirin. It also has a longer duration of analgesia than paracetamol, and we saw this in the earlier slides. The combination of ibuprofen and paracetamol produces greater analgesia and is equivalent to opioids, and that's very important these days in the light of opioid abuse, like, for instance, from codeine and from other opioid drugs. Caffeine undoubtedly confers additional analgesic benefits when compared with ibuprofen. It's the most appropriate non-steroidal to use in patients with cardiovascular and renal disease, where diclofenac is not recommended. So there's a good case for using ibuprofen in the combination drug formulations. So in conclusion, I hope I've been able to present to you understanding of the actions of analgesics gives a basis for the use of these in increasing pain thresholds and efficacy in MMA, multimedia analgesia, multimodal analgesia. Combinations of low doses of paracetamol, ibuprofen, and caffeine at their recommended daily doses in the USA are a safe and effective means of treating mild to moderate pain of varying physiopathological types. I want to emphasize that the doses here are low and are deliberately recommended to be low in the way that the synergy between these drug components is achieved in pain relief. Thank you very much, and I look forward to receiving questions from you, and I hope this has been enjoyable. Thank you.
Thank you so much, sir. Well, before we proceed for question and answer session, I would like to briefly present here the solution offered by Shalina Healthcare in the management of acute pain conditions with the help of this concept of multimodal analgesia. And we bring it through this wonderful product that is Ibucap. Ibucap, each Ibucap capsule contains ibuprofen 200 milligram, paracetamol 325 milligram, and
Rahul,
caffeine.
sorry to interrupt. Your screen isn't shared.
Can you see now?
Yeah. Yeah.
Yeah. Sorry for the interruption. Well, I was talking about that before we move towards question and answer session. I would like to present quickly about the solution offered by Shalina Healthcare in the management of pain conditions by using multimodal analgesia concept through this wonderful product that is Ibucap. Ibucap contains ibuprofen 200 milligram, paracetamol 325 milligram,
Hello.
and caffeine 50 milligram. Yeah.
Rahul, sorry to interrupt. It's gone again. Would you like me to do it?
Well,
Yeah,
I'm
please.
hearing it quite well.
Can you see it now?
Not yet.
You
I'll
can
just
flash
share.
it from your side.
Yeah. Yeah,
No
I'll do
problem.
it. I'll do it.
Yeah. Can you flash the slides, Hitesh, of Ibucap?
Yeah, one second.
Yeah.
Just hold on one second.
Sure. So we have got chance to learn quite basics about multimodal analgesia, and thanks to Professor Rainsford. So I am trying to correlate here in my medico marketing presentation of this multimodal analgesia concept with Ibucap. Let's go to next slide, Hitesh. Yeah. So Ibucap contains each capsule contains ibuprofen 200 milligram, paracetamol is 325 milligram, and caffeine is 30 milligram. Ibucap is recommended to treat the pain associated with headaches and general body pain, mainly due to muscle aches or due to sport injuries like sprain and strain or some traumatic injuries. And recommended dosage is 1 to 2 capsules 3 times in a day. Next slide, please. Okay, move on. So this is brief overview of about ibuprofen, which Professor Rensford has beautifully explained, but I will just quickly take you through this slide. Talking about the efficacy of ibuprofen, it is most recommended first line treatment in the management of acute pain as compared to other NSAIDs like diclofenac, aceclofenac, and aspirin. It shows rapid onset of action in 19 minutes versus 27 minutes of diclofenac, and this action lasts for longer time than aceclofenac. Talking about the safety of ibuprofen, it is considered as one of the most safest NSAID when it comes to gastric safety, and it offers better gastric safety profile than NSAID, other NSAIDs, particularly aspirin. It is ibuprofen is also considered as one of the appropriate NSAID when it comes to treating patients with comorbid cardiac or renal ailments. But in these cases, we need to use ibuprofen dose less than 1200 milligram per day. Also, ibuprofen carries very low risk in bleeding disorder patients than aspirin. Next slide, please. Talking about paracetamol, it is time-tested and well-trusted analgesic agent, and it is also used as a first-line treatment in mild to moderate painful conditions. While it acts centrally on brain in central nervous system, it complements the peripheral action of ibuprofen. And when paracetamol is combined with caffeine, it causes overall augmentation of analgesic benefits. Well, talking about the safety now, it is very important point here. Paracetamol present in Ibucap capsule is 325 milligram, which is exactly as per the US FDA recommendation. And it is very important because it carries very low risk of side effects or any safety issues they occur because of overdosing risk. And furthermore, paracetamol, it is popular for lower risk for gastric side effect as compared to NSAIDs overall. Next slide, please. Well, I will quickly brush up on multimodal analgesia here, which Professor Rensford has explained us. We can see this is a pain pathway here. At the top, brain is there, and in middle, spinal cord, and then coming down at the bottom is your peripheral site, right? And when your injury happens at peripheral site, that pain signal goes to the nerves. It travels via spinal cord and reaches to the pain center in brain. So what is multimodal analgesia? It is nothing but combining more than one analgesic together, and these 2 or 3 analgesic agents, they have different mode of action and they have different site of actions. That is how they produce synergy, or that is how they produce supra-additive analgesic benefits. Next click, please. So here, Ibucap contains ibuprofen, which acts peripherally, and it reduces both pain as well as inflammation. While Ibucap also contains paracetamol and caffeine. That both of them, they act centrally, and paracetamol reduces both pain as well as fever, while caffeine is very popular analgesic adjuvant, and that enhances the analgesic effect produced by paracetamol. So that is how these 3 drugs combining together, they produces this beautiful synergy and supra-additive analgesic effect. So another advantage of combining analgesics together is that these combinations, they help to overcome the analgesic ceiling effect, which professor has explained us, that analgesic ceiling usually happens when single drug is used. If you can remember that graph of ibuprofen stop, or any NSAID stop showing effect after certain dose. So that problem is overcome by combining the analgesic drugs together. And lastly, but the most important, in my opinion, this is the most important point about multimodal analgesia, and that is the dose sparing effect. So dose sparing effect is nothing but when two drugs or three drugs are combined together, they allow us to reduce the dose of each drug, and in turn their side effects are also reduced. And that is what we can see in case of ibucap. For example, caffeine is 30 milligram. So this is optimal effective dose, and there are hardly any chances that it will affect sleep awake cycle, or it will cause any addictive effects. So that is what the beauty of multimodal analgesia. Moving on to next slide. So this slide summarizes about the analgesic synergy created by the combination of these three drugs putting together, ibuprofen, caffeine, and paracetamol. If you see on the left side, upper left side, that is ibuprofen and caffeine. When they have been tested in clinical trials, this combination has shown almost 3 times high potency as compared to ibuprofen alone, and this combination produce higher analgesia as compared to aceclofenac 150 milligram. While talking about on right side about ibuprofen and paracetamol combination, now this combination is US FDA approved fixed dose combination, and it has got US FDA approval just 3 months back. While talking about paracetamol and caffeine, it is popularly known for showing the synergy or analgesic synergy, and it has been tested in many clinical trials. Moving on, please. Well, this is my concluding slide, and I would like to take you through the ibucap journey. Well, ibucap is new for Kenya market or for Kenya healthcare professionals, but ibucap had started its journey almost 2 decades back in DRC when we launched it for the first time in 2002, and followed by that we launched it in Angola in subsequent year, and after that ibucap found its way to West Africa and then to CAR, Zambia, and we have taken this success story now to Kenya. I am purposefully referring here success story because ibucap has got this solid backup of 2 decades of clinical experience of uses of ibucap in millions of patients, and the entire credit goes to the trust shown by healthcare professionals across the region. Well, moving on. Now we reach to question and answer session. And I request here Professor Rensford to help me to answer some of the questions. Well, we are getting questions in live session, and I have picked some of them. Okay, I would like to go for the first question. What is the best pain management practice for osteoarthritis in your opinion, Professor? When we talk about, management of acute flare-up of pain in arthritic patient as well as chronic management of the condition.
Well, ibuprofen, paracetamol, caffeine combination is actually very useful for controlling flares. That is the periodic appearance or occurrence of pain in the joints of osteoarthritic patients. And indeed, these can be applied also to patients with other rheumatic pain. But ibuprofen works very well in osteoarthritis. The general recommendation is to, and this is now following reviews by several international arthritis bodies and the US FDA and the EMEA in Europe, it's best to take these drugs for the shortest period of time at the lowest possible dose. That's a maxim for most non-steroidal and analgesic therapy. And its optimal actions are evident within 2 to 3 days from either ibuprofen or the combination therapies. And the best period is to use them for upwards of 10 days. The 10-day is a sort of a very useful period in which to apply this, because then you know if they're going to be working or not. Now, if ibuprofen or the combination therapy doesn't work after that, then it's an indication for examination in detail, either by getting MRI or X-rays to look at the joints and see what extent of injury there is, and to then perhaps engage the involvement of a surgeon, orthopedic surgeon. But in the main, most patients respond best if they've got mild to moderate pain with the ibuprofen, paracetamol, with or without caffeine combinations.
Great. Well, coming to second question, Dr. Mercy would like to know, since we have discussed about the role of caffeine in multimodal analgesia, and here question comes about the caffeine. Will 30 milligram caffeine affect the sleep-awake cycle, or will it cause addiction?
Well, if you think about the amount of caffeine that there is in a cup of coffee or a cup of tea, this is relatively small. Mostly tea and coffee have about 100 milligrams of caffeine in them. And okay, it's true enough that taking tea or coffee before going to bed can affect your sleep pattern, but the low dose of 30 milligrams is unlikely to have any substantive effects on sleep or even other neurological conditions.
And what about its addiction potential, sir?
Very low. Of course, if people abuse taking the caffeine-containing drugs, then there's a slight increase in possibility of apprehension, nervousness, and so forth. But it's very unlikely, and in the drug combination and for the purpose that is being applied for pain relief, this is, relatively speaking, unlikely.
Okay, let us move on to next question. And this is about the opioids use. Well, amid this opioid crisis globally or in many countries, we see the harmful effects caused by the opioids. Now, in that context, what role multimodal analgesia or the combination analgesics they are going to play in reducing the impact of this opioid crisis, or in opioid sparing effect?
Well, we know that ibuprofen and paracetamol combined together have just about the analgesic effects of opioids like fentanyl and codeine and so forth. And of course, in analgesic abuse, the doses of the opioids is actually quite high, and they are being abused by patients or by individuals who are very determined to have an abuse effect. But I think that the likelihood of any condition developing with the combination of ibuprofen, paracetamol, and caffeine is practically non-existent compared with that of the codeine and fentanyl and other types of opioids, which have been shown to have abuse potential. And in Australia, there was a preparation available there which had ibuprofen and codeine. And in Victoria, uniquely just a strange state, this combination was shown to have some abuse in some individuals. And what they were doing was extracting, they were getting hold of large quantities of these tablets containing codeine, and they were extracting out the codeine and using that to produce an abuse potential. When this matter came to a head, and this is several years ago, the Australian authorities, together with the marketing authorization holder, decided that they would withdraw this preparation containing codeine, and the marketing authorization holder introduced ibuprofen and paracetamol to replace that. And it was shown to have very good analgesic effects, equivalent or sometimes even better than the codeine containing preparation.
Great. Now the next question is related to the current situation. Dr. Benson and Dr. Winnie would like to know what are the current trends in the management of pains associated with COVID-19.
Oh, a very, very important and significant issue at the moment. Some while ago, I think this was back in March, there was a report that came from France that ibuprofen might be causing some untoward effects in patients with COVID. This has actually probably been shown to be not the case. It was a single report, and we're very unsure about the quality of that particular report. But nonetheless, it opened out the issue about what ibuprofen, and indeed paracetamol as well, might be doing in COVID patients. Now, I'm aware of a study that's been done in Denmark, which is about to be published, in which 9,000 patients with COVID-19 had been examined for their non-steroidal anti-inflammatory drug intake. And it looks like there were no untoward effects at all to speak of, or no serious effects in these patients that were taking non-steroidals. Now, we don't know exactly what the incidences were of any effects of the individual non-steroidal anti-inflammatory drugs in these patients. But if they'd been serious, they would have been picked up. And this is quite an impressive study. I don't know when it's going to appear, but it should appear shortly. And also, the US FDA and the British Medicines Regulator, the MHRA, have been looking very carefully at this as a potential problem with ibuprofen. And the recommendations are, or the results from their inquiries and the recommendations are, to continue to use the drug safely in its recommended doses.
Okay, and let us move to next question, which is from Dr. Fred. It is more towards the diagnostic part of painful conditions. Dr. Fred would like to know, how accurately can we measure pain in order to prescribe the right medications?
Well, this requires a physical examination, and it depends on the degree of pain and injury that's causing the pain, or the insult that is causing the pain. And if, for instance, there is clear involvement, musculoskeletal involvement or spinal involvement, that's a case for investigation using either ultrasound, which is actually pretty good these days, as a means of being able to pick up the extent of damage and inflammation. In more serious cases, and where there is available instrumentation, MRI or X-rays with X-ray enhancement. So I think that the physical examination is a priori the first thing that needs to be undertaken. And then you measure what the patient needs in the way of pain relief according to the severity of either the injury or the pain responses. I hope
Okay.
that, yeah, I mean, it's a big question in itself. It could take
Yeah.
several lectures, actually.
Right. Okay. I hope we can still accommodate, I think, last question. Well, Dr. Johanna would like to know what is the best analgesic for children in case of trauma?
Well, I over 6 months of age, ibuprofen is very good, but it needs to be given at doses which are the recommended ones. And these would be in the patient's leaflet, or the description, or that recommended by the pharmacist. I would go along with the importance of using the information from pharmacists to judge the dose in relationship to either the body mass or BMI or physical condition of the individual. But ibuprofen is certainly very effective and very good at inflammatory pain relief in children, and it's generally regarded as safe if used in the right doses. I mean, there are exact nomograms or dosage regimes recommended for children, and these should be strictly applied. Paracetamol is used a lot in children and is favored by many healthcare professionals, and it has a place. These days, combinations of ibuprofen and paracetamol are quite popular and quite safe to use in children, but again, attention to dosage is absolutely important.
Yeah. Great. With that, we have completed some of the questions, and yes, I can see the few repetitions are there, right? And we will still filter off these questions and revert back to the audience who has asked these questions. Well, I would like to thank Professor Rainsford for the wonderful presentation and for the great insights on the subject matter. It was really wonderful experience to learn about multimodal analgesia. I would also like to thank our audience for taking time from your busy schedule and attending this webinar. So with that, I would like to request all the healthcare professionals to tune to our updates. We'll soon bring next webinar. Thank you so much.
Thank you very much indeed, audience, as well, and the sponsors of this webinar.
Thank you.